Thank you so much, Dr. Tripathi, for starting us off. And as many of you heard, the challenges for the role of mechanical ventilation COVID-19 are not only clinical, right? There are health systems-based challenges, there are ethical challenges, there's patient-centered decision-making challenges. But for this discussion, what I would like to focus on is some of the clinical challenges, the nuances to management of these patients. And so for our panel discussion today, in addition, we'll have Dr. Charlie Wiener and Dr. Sanjay Desai from Johns Hopkins University, who have both actively been managing COVID-19 patients in the ICUs here in Baltimore, US. And then from our India side, from AIMS Rishikesh, we have Dr. Tripathi, who you've already met, Dr. Harita I, Dr. Girish Sindhwani, Dr. Ankit Agrawal, and Dr. Gaurav Jain, all of whom are experts in their craft, have actively been managing ICU patients. And as you can see, are masked and scrubbed and in the hospital at this very moment, managing patients. And so the whole of our panel, I believe, may not be able to attend. So focusing on these clinical questions, the number one thing I heard from Dr. Tripathi, and I'm going to direct this to Gaurav Jain, if you're available, is that patients in the ICU have a prolonged stay. So what are some of the strategies that you have implemented at AIMS, at Rishikesh, that are evidence-based to lessen the likelihood of complications in these patients?
Okay, yeah, as you already said that, yes, patients who are admitted to ICU, especially COVID patients, usually had prolonged stays, especially those requiring any form of invasive or non-invasive mechanical ventilation. So one strategy we applied is periodically reassessing them by the expert at least twice a day, and those in-house every hourly. So the periodic assessment was again regarding the respiratory support and the level of sedation required. The second important thing is that we on the daily basis in the morning rounds, we try to give sedation medication to those patients by decreasing the rate of sedation and seeing how the patients are actually responding. The other important thing is just making sure that patient receives adequate nutrition, plus active team for chest physiotherapy. And we made a dedicated proning team, which actually made sure that the patients are, for awake patients are having at least 6 hours of awake proning in a day. And for intubated, it is again more than 12 hours a day. So these are a few measures we tried for it. Plus, if any patient is having any signs of deterioration, we try to put it in the expert panel. We daily had a evening meeting, and we try to discuss it among us what better could be done for such patients.
And so what I'm hearing is active chest physio and proning, and I'm sure there must have been a training requirement for physiotherapists to do this. Do you have any locally developed protocols that we use to guide the management of these patients?
For active chest physiotherapy, because although PMR department is routinely doing that for all ICUs, and we had to increase the strength from, as Dr. Tripathi already said, to 30 to 200. So we did engage all trainees in the PMR department with us, first years, second years, third years. The important thing was daily assessment of how they are doing and what they are doing, so that if any deficit is there, we could do it in the form of short workshops, what we organized in between at least once weekly to cater that.
Thank you very much. So Dr. Desai, I'm going to ask you a question next. One of the things that our colleagues at AIMS Rishikesh have identified that we did all of these additional strategies to manage a severe hypoxia, but we have seen with COVID patients that despite mechanical ventilation, adequate oxygenation, persistent hypoxia was often a cause of mortality. What additional rescue strategies that are evidence-based have been used for patients with severe hypoxic respiratory failure? such as manual bagging or ECMO?
And we'll probably get to some of these in the case. I think that it depends obviously on the resources that are available at the setting that you're in. For us, we are fortunate to have all of the quaternary types of resources. So beyond proning that was described, we use pulmonary vasodilators, paralysis, and then ECMO is a possibility as well for us. Our experience with ECMO has been good, but it is not as evidence-based in terms of randomized controlled trials as we would want in other types of interventions that we use. However, with refractory hypoxia, and despite all of the other interventions that we've used, we will consider ECMO in patients that are younger, have a BMI that is not too high, and ideally have single organ disease.
Thank you very much. One of the other challenges that I heard mentioned by our colleagues at the start was the timing to mechanical ventilation. And so, Dr. Sindwani, I wanted to ask you, and I think there is no clear answer here, but what is the optimal timing for invasive mechanical ventilation, and how much non-invasive ventilation is too much?
So thank you very much for the question. This is a really challenging issue to address, like how much can we go for non-invasive ventilation. We need to keep assessing the patients on NIV in terms of clinical assessment. How much are they tolerating the pressures, how much are they tolerating the machines and the interfaces. So many times if we come to see that the patients are really not improving over maybe 2-3 days, we sometimes tried, but eventually it is that sometimes we get to see patients with happy hypoxia and the patients are just not getting over this thing, and so eventually we have to take a call based on clinical conditions only.
Thank you very much. And is there any timing that you can give to the crowd, like too much? What do you teach in your ICU?
So it's very variable on patient to patient basis. We have seen patients who have tolerated non-invasive ventilation up to 7 to 10 days even, and they have managed to survive. And it all depends upon the motivation, how the patient is getting and to carry on with the ventilation. So sometimes patients do not tolerate NIV for a few hours, and sometimes they are able to manage for a few days. So it's difficult to give a timeline as to universalize this for the patients.
Thank you so much for your insights. One of the challenges is this prolonged ICU stay. We're talking 30 to 40 days for patients. It's a huge consumption of resources, and that with a national crisis on oxygen availability. Dr. Ween, I wanted to ask you, are there any evidence-based oxygen conserving strategies that can be employed to preserve our rare oxygen supply?
So the short answer is I'm not aware of any. And one of the controversial issues is what is the right or most appropriate lowest threshold for oxygenation? How low can you go? Many of my colleagues in India live in elevation. Many of them walk around with saturations that we would put supplemental oxygen on in the United States. So, and there probably are genetic and hereditary factors that determine your tolerance to oxygen, but there's no evidence-based answer to that at all.
Thank you very much. I wanted to ask another question about the practical management of the COVID-19 patient. So secondary bacterial and fungal infections, I mean, indeed, TB lung in India is of concern, contributing to this picture of severe hypoxia. Dr. Sindwani, can I ask you about the role of BAL to diagnose secondary invasive infections, and how, if it's useful in intubated patients or not, is it recommended? And how are you keeping your practitioners safe?
So that is a very important question. As we know, the infections, the super-heated infections are common in patients with COVID-19, as with other influenza and other viruses. In the previous pandemics also, we have seen the secondary infections, super-hereditary infections do happen. And the strategy to sample the lower airways, basically, as we know, is twofold, is either non-invasive sampling by endotracheal aspiration or invasive sampling by bronchoalveolar lavage and protected brush. As with the evidence and because of true facts, we are sticking to the policy of not resorting to invasive techniques, and the reasons behind are, number one is bronchoscopy is as we know, is a highly aerosol generating procedure, and there are health cross infection hazards to the healthcare workers. So, and the second reason is that the evidence, at least 3 published studies I know that state that it doesn't really make a difference if we go by invasive or non-invasive sampling in terms of length of ICU stay, the mortality outcomes, and the days on mechanical ventilation. So it really doesn't increase the outcome if we do by invasive sampling. So as a policy in our institute, we were not doing invasive sampling by bronchoalveolar lavage as the first thing. So only in selected cases we used to do bronchoalveolar lavage.
Thank you so much, Dr. Sindwani. I have 2 more questions and then we're going to end, but one from the chat, and I'm going to direct this to Dr. Desai. Dr. Kungwang would like to ask if patients on prolonged non-invasive ventilation tend to adapt to it, and can you try and reduce the FiO2? Also, is there a chance that these patients develop long-term sequelae of pulmonary fibrosis?
Yeah, so I think certainly you want to, it's good if they adapt to it. I mean, it's good that you can try to avoid invasive mechanical ventilation, which will be more complicated. We know mortality will increase if that happens. So I think you want people to do well with it. I think you want to decrease FiO2 as tolerated. As Dr. Wiener said, we don't know what we should tolerate, but decreasing it to what you would consider a tolerable level is important. And I think fibrosis can occur. So ARDS, whether you're treating it with non-invasive or invasive mechanical ventilation, is an inflammatory syndrome from which you will have some consequences. The degree of injury that is irreversible, we really can't predict at the beginning. Ideally, we would think that if they don't require mechanical ventilation, that injury, the irreversible portion, will be lower than if they required mechanical ventilation. But we don't know that. So I think there's always the risk of some irreversible injury.
Thank you so much. So last but not least, I know we're going to talk a lot about the benefits of proning in mechanically ventilated patients as a very early strategy to improve clinical outcomes. But Dr. Ankit Agrawal, I was wondering if you could share your experience on proning within your ICUs. How long did each session last for? What were some of the challenges that you faced, and any advice you can give to practically implement proning within ICUs?
Proning, we practiced in almost all the patients in our ICU, and we aimed for proning at least 12 to 16 hours out of 24 hours duration. And for that, we had a dedicated team whose exclusive job was only to prone the patient. And that team used to prepare the patient. While turning, that team used to take care of the lines and the pressure points so that there are no prolonged complications of proning. One thing that we did in our ICU in terms of proning was we tried to prone each and every patient, whether that patient was on mechanical ventilation or not, whether he was on any mode of oxygen therapy, but we did try to prone that patient for as long as possible. And we did this with the aim of not only treating but delaying the onset of means if the ARDS getting more severe, or if the patient has not ARDS, then going into ARDS. So we had the aim of delaying the symptoms of ARDS, and this just gave us more time for the inflammation to subside or for the other treatments to act. So in these terms, we had a lot of benefit of proning.
Thank you so much. So colleagues for AIMS Rishikesh, you're going to be also contributing to our expert review that we distributed to all of our registrants. So we hope that you continue to share your wisdom and practical guidance on how your strategies can be implemented across ICUs in India.